So I'm Dr. Juliana Chan, and I have Dr. Elaine Chow, and then also Dr. Jones Chan that you're going to see in a minute. So today, I think we're going to talk about something which is very important for all of us, because all of us, whatever specialty you're going to be in, you'll be using just some drugs. And there are many drugs which are commonly used, in all specialties, whether in the hospital setting or in the community settings. And as I indicated in our introduction, that really, we are dealing with complexity, dealing with a lot of connectivity and also unpredictability. And it's these interactions, I think, that also make medicine very interesting and challenging. So what we're going to do today is Dr. Joan will actually go over, some of the rationale, some of the program, and some of the evidence that really support the importance of every now and then reviewing the medications that are being used for patients, because every patient is different, but within the same patient, things also change over a period of time. And this review is very important because at the end of the day, we have to maximize efficacy and also minimize harm. And then we will have a couple of interesting and really quite alarming cases to illustrate, how, the inappropriate use of medications can really create a lot of problem. So let me just start with 3 cases, okay? So I apologize that it's all related to diabetes, but I think because so many people have diabetes, probably 30% to 50% of patients attending the outpatient clinic or in the hospitals have diabetes. And of course, diabetes doesn't exist on its own. It can, coexist with many other risk factors and complications. And as such, they will receive a lot of drugs. And this is really where drug-drug interactions and the problem can arise. So let me just show you the first one. So this is really the overall, outline. Medication reconciliation, medication review, de-prescribing. We don't keep adding, right? Everything you add one drug, you have to ask yourself, is it going to make a difference to this person? And then can we simplify the med regimen? So these are every time when you actually write a prescription, these are the things that we ask ourselves. Does the patient really need it? Is it going to make a difference? Am I going to actually introduce harm? And also, do these patients need all the medications that he or she needs? And is there any medication that he or she needs but that has not been prescribed? And different approaches addressing this important therapeutic strategy. So these are 3 cases that, just some of the patients that I see all the time. So for example, 60-year-old lady, she had 10 years of diabetes. Her A1C was around about 9 to 11% all along. So this is her medication. So it's on a sulfonylurea. Because 160 milligram BD, pioglitazone 30 milligram daily. This is a TZD. She's on Janumet, which is a Januvia plus metformin, a DPP-4 inhibitors. And then she's also on insulin, protein 36 units and 24 units at night. She's also on Zocor, a statin to reduce the lipid. She's on calcium channel blocker, amlodipine, and also a beta blocker. So when seen at the clinic, her BMI was 28. And then blood pressure was 160 over 100. A1C was 9.8%. And then also LDL cholesterol was 2.8. What is the diagnosis? Anybody hazard a guess? What is the main issue here? Is she at go or not at go? Anybody typing messages? Okay, anyway, in the interest of time, so obviously she's not at any goal, right? Blood pressure should be 130 over 80, A1C should be really preferably 7%, LDL cholesterol preferably, less than 2. And but the fact that she's on so many drugs and she's not at goal, then actually, we have a major problem of compliance. And of course, you have to realize that all these drugs, they have been approved. They have undergone very careful evaluation. Most of the blood glucose lowering drugs would reduce A1C by at least 0.5% to anywhere 1% to be approved. So, she's already on 4 oral drugs together with insulin, and her A1C is not shifting. So there is some issues about this compliance. The fact that, statin is also one of the most powerful drugs. Once you give the statin the right dose, usually the LDL cholesterol will come down by 0.1, millimoles per liter. sorry, about 1 millimoles per 0.5 to 1 millimoles per liter. So here is so that's one of the issues. Okay. So secondly, very similar again, 60-year-old lady, 5 years of diabetes, A1C 7.5%. Also on very similar drug. She's on metformin 1 gram BD, glucosamine 160 milligram BD, Zocor 20 milligram daily, amlodipine 10 milligram daily. She's on Senecot, okay, which is actually a for her laxative, right? And then lactulose, also laxative, and she's on a bit of the antidiarrheal drug. She has been losing weight, okay, and also complain of a lot of GI complaints. So he has actually undergone a lot of GI workup, upper, lower endoscopy. She had cancer marker screening. She undergone PET scan and CT abdomen, and all of them were negative. Do you know the reason why? What is her main problem? Why is she having a lot of diarrhea? Again, we do actually see this not frequently, and sometimes these people end up going to see all kinds of specialists. And about 10% of people do have some intolerance with metformin. And so, the good thing, I think sometimes it's worth actually trying to reduce the dose or change it to a long-acting formulation with lower GI, sorts of side effects. So, of course, it doesn't, when a lot of people have a lot of side effects, complain, maybe we should review the medication first. And then, of course, we might need further investigations. Now, this is a 70-year-old lady. So she's been followed up in the GLPC for 20 years, okay, for diabetes. And then, these are the typical medications. Remember, 20 years ago, these are standard medications. For example, she's on metformin, she's on glucosamine, she's on gemfibrozil, which is a fibrate. She's on beta-log, okay, and Datrix. So these are the 5 most common drugs, I think, given in GLPC, about 10 or 15 years ago. And then, of course, time goes on, A1C get worse. Pioglitazone is the third drug that comes in, right? And then later on, they have alpha-glucosidase inhibitors, and then later on, they start having all these new drugs. So these are old-fashioned drugs then. She actually had joint pain on and off, right? And anyway, her A1C was not good, 9.5%. And her body weight was 52 kilogram, serum creatinine 140 micromoles per liter. She was referred to SOPC for poor glycemic control and also losing weight. Okay, with high A1C and losing weight, this is not very good. All right. Okay, so she's actually not having enough insulin to use the glucose, and she's not burning her fat. So she was put on insulin. And her cholesterol was highish. So, she was put on a statin, and there's a couple of statins being used. Okay, Crestor was actually given in this case, a pretty high dose as well. Because she had a lot of joint pain, which is probably related to her gout. And the fact that she's actually naturally a diuretics, together with might also be contributing that, okay, together with diabetes and metabolic syndrome. And she's been actually getting NSAID, okay, non-steroidal anti-inflammatory drug from GPs on and off. So this time, she also went to the GP, and then she was admitted a few months later with muscle pain, nausea, and drowsiness. So this was a case, a few years ago that we saw. Sadly, the patient died, okay? So you could see that she has developed acute renal failure. Firstly, you could see that the serum creatinine 140, do you know the eGFR? You could see that this patient actually had very low BMI, right? So she doesn't have a lot of creatinine on board, right, from her muscle. So you can actually use this online calculator, which really only need to put in the age, the sex, and then also the serum creatinine, and you will actually work out the eGFR. In this case, this was really just under 40. So in fact, this patient has actually got grade 3 CKD, okay? And with that, actually, the gemfibrozil is already contraindicated. The fact is, she was also given Crestor, okay? So both of these drugs are actually excreted by the kidney. So there is a potential interactions, okay, between these two drugs. And then on top of that, she was also given, this NSAID. As a result, the renal impairment get further impaired. And so, there was further accumulation of both drugs. And so then, of course, we got into acute renal failure. And then she also had rhabdomyolysis because of the jam fibrosis-induced rhabdomyolysis because of the interactions with the statin together with in the presence of a renal impairment. And so, ultimately she succumbed. So the point I want to make is, this person come to the GLPC, and then I think we will really need to, review the medications. Given the fact she already have 20 years of diabetes, the medications might be a bit old-fashioned. Clinical status has also probably changed, and so as a result, all her risk factors and also her medications will need to be readjusted. So I'm just using 3 simple cases. No, simple or not, right? They're all related to diabetes, but these people, have multiple risk factors using very common drugs, but they can lead to problem if not used properly. So with that, I thought I'll just set the scene for Dr. Juliana Chan to really go over, some of the rationale as well as some of the strategy for medication sort of reconciliation. So with that, I'll pass it to Jones. Okay, thank you.
Thank you, Professor Chan, for her introduction of the cases. I want to emphasize and supplement about the rationale of these the cases that she illustrated. First of all, is don't believe that the medication record in our computer system is really the thing that the patient is taking. Okay, many a time when you prescribe the medications, that's actually the compliance is actually maybe just more than 50%. Okay, so for the first case, when the patients for some event when she admitted to the hospital, and if you do not bother to ask her about the current drug usage and also the dosage, and then you just prescribe following the computer system, prescribe the same dose, and then the patients actually may develop hypoglycemia after admission. If this is not really the drugs that she's taking actually. And the second and the third case illustrate actually medicines is for good, okay, is for therapeutic outcome. If it is used appropriately, but if it is used inappropriately, or if the patient's condition changes as she is getting older or her renal function is getting deteriorated, and then you just copy the medication all the way, and then actually the medications become inappropriate when the patient ages. Okay, so I'm going to talk about the different approach to review these medications. The first one would be the medication reconciliation. What is that? That is a process of comparing the patient's medications orders to all the medications that the patient has been taking. So the purpose is to avoid medication errors, such as omission, duplications, dosing errors, or drug interactions. So imagine if you are the house officer or the intern when you are going to admit a patient to the ward. First of all, you must take the history and physical examination as well, and then you are going to prescribe drugs. So the baseline background history, you will want to gather all the medications list from the patients and also from any other sources, such as the relatives, caregivers, and also from the computer's system to get her drug regime. So you create a drug that is her current drug use list. And then you are going to give her some new medications for treatment of the reason why she's coming to the hospital. For example, infection, you will want to give the patients antibiotics, maybe some other drugs such as anticoagulation if the patient has thromboembolism. So you will want to develop another list of medications. And then you compare both of these medications to see if there's any drug problem, duplication, interaction, etc. So you would want to make some clinical judgment and decision. If you gather all the complete drug list, it will end up with a lot of medications. Some of these medications actually are for PRN use, that is occasional use when the patients need it, right? So, but if you still copy these drug list to the current drug list, and actually the patients may not need it, and then you just create problem. So finally, you will make some decision and then communicate with the patients and the care providers when the patients has some transitional state change of the conditions, and then transfer from one healthcare provider to another healthcare provider. For example, like discharge from the hospital and transfer to non-acute hospital, etc. So I will illustrate one case here. Is a gentleman comes in with acute confusion, right? He has a history of high blood pressure, hyperlipidemia. And then not until when the pharmacists go to the ward and then perform the medication reconciliation, and then we realize the cause of his problem of acute confusion. He had done a lot of tests, including the CT scan of the brain, blood tests, etc., but no one knows really why he has developed confusion. And then the pharmacists found out that actually the patients before hospital admission, he was given some medications with the fancy names, brand name of the medications that actually we do not familiar with. So we have to check both. So the names of the drugs include Abrosol. This is a kind of mucolytic. Frabuco. In fact, this is it contains a combination of drugs, that is chlorpheniramine, paracetamol, and pseudoephedrine. And then Sobriderm, and also another one is Asmeton Strong, which consists of aminophylline, chlorpheniramine, and also loscapine. As you can see that here, there are some duplication of medications. Perhaps the GP doesn't know it, okay? Because these medications are embedded to the name. And actually, when the GP prescribes this, he may not know that there are some duplication. And secondly, some of the medications, in particular, the antihistamine, has high anticholinergic effect. So in an elderly male, he may develop acute delirium because of the use of the too much anticholinergic. And this probably is the culprit of his problem. So performing the medication reconciliation is quite important when you receive the patient and admit the patient during acute hospital. So who is going to do the medication reconciliation? The pharmacist, nurse, and physician's assistants can do it, right? So when we are going to do it? At every transition of care in which new medications are ordered from A&E to ward, medical ward to other ward, acute hospital to non-acute hospital for rehabilitation, and then discharge home. Any transition of care, we have to probably perform once. So the process I'm not going to repeat, but as a house officer or an intern, you will probably want to gather all the medications history from any sources that you can. And then review the medications used, and then do a rationalization of the drug use, and then gather all this and complete, and then try not to duplicate the medication and stop some unnecessary medications, and then convey this message to the next caregiver. All right. So this is the cycle of the medication reconciliation, and the purpose is to reduce medication error, right? So there are a number of causes leading to the error. For example, some drug choices problem, which may be associated with a lack of effectiveness, or some drugs which may be associated with increased risk of adverse drug events or effect. And then also the causes contributing to the problem could be the drug selection, drug form, dosage form, selection of the dose in incorrect duration, and problem in the regimen and frequency, etc., etc. So you want to document this problem and then try to convey the issue to the next carer. So obviously it takes time, right? This is the experience from the United States, Chicago. The pharmacist went to the ward and then performed the medication reconciliation. So if you want to do a complete process, it takes about 21 minutes per person. Okay, but I expect it would be even more in Hong Kong, because many a time our elderly people are not as well educated, and they even do not know the name of the medications, because all the medications are in English. And unlike in the United States, many of them may know the name of the medications. And in some situations, patients are encouraged to bring all of their medications to the hospital when they are admitted. The way we call it a brown bag approach, okay, brown bag approach. That is the brown bag containing all of the medications that the patient is taking. So they would want to bring all the medications with them, and then and give these informations to the doctor for the doctors to, perform the medication reconciliation. But nowadays, I seldom see this practice in our patients. So how effective is this medication reconciliation? People have done some systemic review and meta-analysis concerning the clinical outcome. That is, we know that this is a medication review or reconciliation. We are going to increase or decrease the number of medications. So many of these clinical trial or randomized control trial can give you some meaningful drug-related outcome. So perhaps the number of drug reduced, the cost of the drug reduced, but this may not necessarily transform or translate to the patient's outcome, clinical outcome. But in this systemic review and meta-analysis, the author found out that perhaps it is also effective in reduce the risk of all-cause hospital admission by about 19% in here, and also reduce the all-cause of emergency department visits by about 28%, and also reduce the drug events related hospital revisit, rehospitalization, about 66%. Okay, so this is all about the medication reconciliation. I just want to comment that the message is that many of these medication reconciliation are performed by the pharmacist instead of doctor. Okay, and it can also be performed by nurses. Unlike the medication review, which often is require higher level of rationalization of the medications, so it require knowledge in the pharmacology and about why the patient is taking the medication. So this is a very clinical decision. So many a time, a doctor would perform this medication review. So what is medication review? It is a structured, critical examination of patient's medication with objective of reaching an agreement with the patients about the treatment, optimizing the impact of medication, minimizing the number of medication, and reduce wastage. So as you can see here, you have to have a good communication with the patients. Sometimes the patients may have clinical condition changes. For example, from good diabetic control to bad, or from bad to become a lot of comorbidities, or even end organ damage, chronic kidney disease, or sometimes during the treatment, they develop cancer, and then they end up into end-of-life condition. So with the condition changes, the same disease can have different burden with the medications to the patients. So perhaps maybe the best interest of the patient may change when they develop cancer. The goal of the diabetic control, the goal of the lipid control, even though if the patient has ischemic heart disease, may become less important to the patients because of the limited life expectancy or survival. So according to the patient's goal, according to the patient's wish or interest, we may change the medication accordingly. So there are 3 types of medication review. Depends on the resources that we put into the service or the program. The least useful or the least resources put in could be the prescription review. Okay, you just look into the computerized prescription system, and then try to gather all the medications list, and then balance the pros and cons of each medication, and then rationalize the list. But this is effective because actually, if you do not communicate with the patients, it just not achieve the goal of the medication review. So in the clinical study, and also the recommendations is not good enough. So we would want to do at least the level 2, that is the concordance review. Just like when Professor Chan mentioned, why the patient has poor diabetic control, it's most likely that despite a lot of medication has been given, even though the dosage has been increasing all the time, and then the patient still have poor glycemic control, is because that the patient has poor drug compliance. And then you have to address the patient's problem, why she didn't take the medication accordingly. Could there be any side effects when the patient is taking the medications, and why she's not taking it? So you have to address the problem, so have to improve the medication, the treatment goal. The third one is the best one. That is the clinical medication review. You have to address the issue of the patients about the use of the medicines in the clinical conditions. It usually rely on a face-to-face review. Sometimes I find it is very time-consuming. You know, the patients could be dementia, to have dementia. The patients can argue with you, sometimes even on a very simple tablet of multivitamin. Okay, because it may means importance. It may be quite important. They may have the belief that the multivitamin is very important to them, but actually we think that, oh, this is not really important, and then the patient has problem of polypharmacy, so we want to omit it, but we have to convince the patients that this is not necessary, and then it doesn't have any significant therapeutic use with the multivitamin. And then you have to spend time on every medications, and then you have to convince the patients. So many a time the medication review can be held in conjunction with the medication reconciliation. So who is going to do this? As I said, doctor, pharmacist, and also qualified nurse after training. So there's no standardized format, and of course you have to consider a lot of points during the review. But overall, just to simplify this table, I would think that we have to come to a conclusion that medications should be appropriate for the patient's needs, effective, cost-effective, and then whenever there are some indication for the test, you have to offer it. And I will later on tell you why a monitoring of the therapeutic or the side effect is very important. So when are you going to trigger you to perform the medication review? Just like diabetic complication screening. Perhaps because of the population aging, many patients is on polypharmacy, a lot of medication changes throughout the time when they comes into the hospital and out of the hospital. So at least we would want to do a routine medication review, perhaps maybe 2 years or 3 years time, okay? This is the minimal. But when the patients admit to the hospital because of possible adverse drug reaction, you would want to do the medication review. So perhaps this screening questions is for the nurses or house officer or interns. When you come to the hospital, the patients comes to the hospital, you can do these screening questions to try to see if the patient has any medication problem. For example, you may ask the patients, do you have any problem with the medication, as an open questions? Have you ever experienced missing of the dose? Do you find the regimen too complicated? Do you have any problem in missing the medication, or cannot take the medication on time, such as like these questions? And of course, if it turns out to be positive in any of these questions, you may perform the next or more time-consuming medication review as the therapeutic outcome. And also, there are some tests I want to introduce to you that these tests may be useful during your assessment. First of all, is the Beers criteria. It is an explicit list. What does the explicit means? That means it is list out that actually the name of the medication that should be considered inappropriate for elderly people. And for example, it is listing alpha blockade if the patient has postural hypotension. So they will list out the medication's name. So this is user friendly, okay, quite easy, quite understandable. And some people apply these criteria to the computerized support system, prescription support system. And whenever you type the name of the medications in the computerized ordering system, there would be a pop-up of alerting you that this medication is considered inappropriate in elderly. So would you like to choose some other example, some other drugs option? So this can be done in the computerized system. And the best criteria also lists out several categories of medications considered to be potentially inappropriate, such as in most circumstances, under certain situations, for example, patients with heart failure, syncope, delirium, falls, or cognitive impairment, and patients with the medications that can exacerbate or worsening the underlying problems, such as GI bleeding, SIADH, and causing hyponatremia, hyperkalemia, behavioral and psychological problem of dementia, etc., etc. Some medications can have a drug-drug interaction. Some medications could impair renal function, and some medications have strong anticholinergic properties that can interfere the patient's cognitive function. So this is just one of the examples listed in the best criteria. For example, you may not familiar with all the names, but just have a glance of the names of the medications. For example, hydroxyzine, the brand name is Atarax. Many a time this medication is prescribed for the patients for itchiness. It is a very strong anticholinergic drug. So if this is a elderly patients, try to avoid this, right? Patients with postural hypotension, so some drugs with short-acting, for example, Minipress, for example, doxazosine, they could have a significant postural hypotension, so avoid in the elderly. Digoxin, quite commonly used, but actually it should be used with less favor nowadays, because we have better alternatives for treatment of heart failure, for treatment for as a nodal blocking agents. But sometimes we still need it for patients with refractory heart failure. So you should reserve it as a second line in treatment of atrial fibrillation or heart failure. So avoid, if the patient has advanced chronic kidney disease, try to limit the dosage to less than 0.125 milligram per day. If a person has mild kidney problem, so you try to avoid using long-acting sulfonylurea because they have high risk of prolonged hypoglycemia. Another useful tools for choosing or screening out any inappropriate medications is the stop and also the start criteria. When there are a lot of rules, I'm not going to tell you one by one, but just list some conditions. For example, the stop, try to avoid use of digoxin as a first line in the heart failure. If you still require to use the digoxin, try to limit the dose if the person has renal impairments with the GEFR less than 30 ml per minute. If you want to treat patients with systolic heart failure or heart failure with reduced ejection fraction with combination of ACE inhibitor or angiotensin II receptor antagonist, and also with the aldosterone antagonist, you must monitor the renal function. Okay, so these are the stop criteria. But the start criteria is consider the therapeutic use of the medication is very important. And whenever you have opportunity, you try to start this medication. One of the things is you should consider anticoagulation in patients with chronic atrial fibrillation, right? Unless the patient has strong contraindication to that, or maybe other drugs should be, you would want to use the anti-resorptive drugs for patients with osteoporosis or osteopenia, etc. So you would want to consider this medication. So another tool would be the anticholinergic problem. Okay. So some of the medications I list here actually are quite commonly used, but people may not know that it has high anticholinergic effect. For example, older generation serotonin drug antagonist inhibitor, such as the paroxetine, it has relatively high anticholinergic effect. So a combination of these medications, if the score is more than 3, it is considered high risk, and then you would want to reduce the use of these drugs associated with anticholinergic effect. Obviously, there are some medications with known anticholinergic effects. For example, drug for treatment of urinary incontinence, overactive bladder. These are the drugs that you would be quite familiar with known anticholinergic effect, but not every single drug here. Okay. So whenever you are in doubt, you can refer to any online scoring website. So I list out here. This is quite user-friendly, and you just type the name of the drug and maybe a combination of these drugs. So it will give you the final marks of the anticholinergic score. So after doing this rationalization of medication, you would want to document it, implement it, and communicate the change with the subsequent caregiver. I list out an example here I recently encountered. Okay, a lady with atrial fibrillation, and she has been given rivaroxaban for quite a long time. Okay, but 2 years ago, she came into the hospital because of poor control of the heart rate. She has fast atrial fibrillation. So the doctor changed metoprolol and substituted it with dronedarone. So the patient was quite happy because the heart rate was quite well controlled subsequently. She had not had any hospitalization for 2 years. Not until recently, when I encountered the patient during the medication review in the ward. Incidentally, we found out that she had a deranged clotting profile. Her INR was up to 3 or 4. And then it is uncommon even if the patient is on rivaroxaban. And if the patient has quite a significant deranged clotting profile with the use of new oral anticoagulant, we would worry about overdose of the medications. Although we do not have exact, the clotting profile may not be a good test. So we order the rivaroxaban level. Okay, we are actually testing the factor 10A activity, and it turns out to be quite high. Overdose, not within the therapeutic range, and this is suggestive of an overdose range. So why is that? Why over the 2 years the patient has been given the same medications and without problem? The computerized system didn't alert us about the significant drug history interaction. It's because of the limitation in our computerized system. The prescription computerized support system is that it only alert us about the grade A and grade B significant drug-drug interaction. For grade C or D, that is, you have to close monitoring the patients, or you have to modify the drug option, the drug treatment. They will not list out as a prompting. So this is a grade C. The patients require close monitoring and investigation. But throughout the 2 years, the patient doesn't have any blood test about the clotting profile, and we do not know whether the patient has bleeding or not. But luckily, the patients survive. Okay, so finally, we document it and then convey to the doctor, and then the doctor accept our suggestion and then change the rivaroxaban with edoxaban, which has less drug interaction with duranderon. So how effective is this medication review? Again, many of the study randomized controlled trial suggesting that it can improve the drug-related outcome. That is, it can increase the drug change to a more appropriate drug. It can reduce the dosage. It can reduce the drug-related problem. It can reduce the number of drugs that the patient has taken. But it probably may not be able to reduce the quality of life or reduce the drug cost, because many a time we are doing the medication review, we would reduce the use of inappropriate drug, but at the same time, we would add another drug. We would add some drug that is considered important to the patients, that is using the START approach. Can it improve the clinical outcome? Yes, it may reduce falls to the patients, but unluckily, we are not able to prove that this approach is able to improve other outcomes, such as improvement in the cognitive function, improve in the survival, improve in the hospital admission, etc. So I want to leave the remaining time to Professor Chow to talk about the prescribing.
Okay, thank you very much, Jones. So I think for the next part of the talk, so we will talk about de-prescribing. So so we talked about how to review medications, but actually, so I think so. This prescribing is actually a quite important thing, because we patients who do not need the drug. Why continue taking it? So I think it's just a systematic process of really thinking about which drugs the patient really needs to take, and also identify drugs that can cause potential harm more than benefit. And I think a number of factors we need to consider, including the individual patient's care goals, also the level of functioning, whether the life expectancy, so whether they're really going to benefit from a drug, and also a patient's individualized choice, whether they prefer to take it or not. So I think de-prescribing is something we should maybe do all the time, but in particularly when we think about there are some suspected adverse drug reactions, for example in old adults when they have delirium or falls, and also sometimes especially when people maybe at an end stage, end of life situation. Again, particularly in those situations, we don't think about the risk benefits of continuing certain drugs. Okay, so I think the best way to go through the process of de-prescribing would to follow this protocol, and this is a 5-step approach. Is written by Ian Scott, and this article in JAMA describes this quite nicely. So I think you should follow a 5-step approach. First is to, number one, ascertain all the drug the patient is currently on, and think about the reasons they're on each one. 2, secondly, then you think about the overall risk of drug-induced harm. So how likely is this patient going to be affected by, being on polypharmacy? Third, so think about the each drug and the eligibility to be discontinued. Think about whether there's any indication of it, whether this is the patient is going to really benefit from this drug, and then we can prioritize the drugs for discontinuation, and then implement and explain these changes. So I think maybe better illustrate this process using a case. This is a real case. I think Dr. Chan encountered this case maybe a few months ago. So this is a case of Mrs. Y. She's a 56-year-old lady. So she's a non-smoker, non-drinker. So in fact, she is a motor-driven wheelchair when she goes out, and she has a number of medical issues. So here, she's got type 2 diabetes, she's got hypertension, she's got obstructive sleep apnea on CPAP, she's got morbid obesity, hyperlipidemia. She has also got a history of asthma, hemorrhoids. She's got some GERD, reflux. Also, she's got depression, where she's under follow-up by psychiatry. Also, she has got problems with cervical spondylosis under orthopedics, and also she has also got some problems with bilateral early cataracts. So given these multiple conditions, actually, she also has got multiple patient follow-ups. Actually, this is fairly common. Yeah, Dr. Jones-Chan would agree that people are often under multiple specialties. So for her diabetes, hypertension, she's under family medicine. So she goes to the respiratory clinic for asthma and OSA. She goes to psychiatry, who just prescribes her depression medications. She's also seeing surgery for hemorrhoids, orthopedics, who also maybe prescribe her some painkillers as well, and seeing ophthalmology for her cataract problems. So I think she was admitted recently for transient visual loss. There was a query about whether this could be amaurosis fugans, and in fact, so she was actually pending MRA investigation. So this is a true list. So these are the medications that she was discharged on. So in total 32. It's a rather shocking list. But I mean, I think this list was arrived with medication reconciliation, and in fact, really bringing together all the medications that she was prescribed on these 5-6 clinics. So I mean, 32 medications. Any comments, impressions there? What do you think? Do you think, is it possible that she is really taking all these medications? I don't know whether where she finds all the space to keep it at home as well. So what would you do if you're the doctor? Would you consider de-prescribing some of these medications? You might. And which ones would you stop first? Okay, so I think let's go through the process. So first of all is think about the indications. So really, I think, every single doctor, whether you're the houseman, the intern, or even the in-charge physician, when you look through a list of medications, you should be able to put an indication for each of the single drug that you prescribed. Otherwise, why would you prescribe it? So I think the first process is to put an indication for each drug. So actually, most of the drugs there is a good indication. So for example, the amlodipine is for her hypertension, simvastatin for hyperlipidemia. So she needs to be on several glucose-lowering drugs for diabetes. So in fact, she is on the protophane insulin. She's on the glimepiride, a sulfonylurea, alogliptin, a DPP-4 inhibitor, and metformin. Okay, so I grouped all the inhalers that she is on for asthma. So, for example, she is on a Ventolin, salbutamol, which is as a reliever therapy, possibly. I think she should be on some regular preventive therapy. So that's possibly the Beclofort and the Flutiform inhaler, and also Montelukast, which probably is for the asthma as well. I put query the fluticasone nasal spray. So people quite often get allergic rhinitis on top of the asthma. So maybe that's also related to that. Again, you could see a number of drugs that she's probably on for depression. That includes escitalopram, which is an SSRI. So these other drugs, we're not quite sure. Possibly, again, they've been prescribed for depressive disorder, which include, trazodone, amitriptyline, and zolpidem, a benzodiazepine. Maybe she needs a PRN for sleep, and also agomelatine, which is again atypical antidepressants. She's also puts on another drug, gabapentin, probably for her spondylosis problem and with chronic pain. And then she's on loads of medications, so for hemorrhoids and probably to try to relieve her constipation problem. So these medications I put for her GERD. And then the other ones, I wasn't quite sure why she's on that either. So these include some initial creams like fusidic acid cream, hydroxyzine zinc cream, and some Piriton. Not quite sure why she's on that. Okay, so I think first, so we've grouped and think about the indications of these drugs. So, what do we think? So the second thing is think about the overall, risk of drug-induced harm, and to just decide how much we need to deprescribe. So I think a number of factors which would include, the number of drugs. Obviously she's on 32 drugs, so very, very high levels of polypharmacy. And think about, whether, there are certain high-risk drugs which have a higher propensity for causing adverse drug reactions. So here, she's on, multiple psychiatric drugs and with potential sedative effects. So again, we need to think about, this will guide us to how many drugs we need to think about stopping. And again, other, patient factors, for example, someone with multiple comorbidities, and, also people with multiple prescribers also, makes it more likely they might get harm from being on multiple drugs. And I think another final thing which you think about is, non-compliance and non-adherence, which Professor Chan and Dr. Jones-Chan all talked about just now. I think this is very important because, realistically, most patients, would say, oh, doctors, how can I manage to be on so many drugs? And if someone is really on 33 drugs, you need to think about really, are they taking it? So if you, like, for example, this lady, she was on something like, 5 different inhalers. Is she really using the preventive therapy appropriately? Same for the diabetes medications. We need to see, are they generally taking all the insulin? Is she really taking all the oral medications, and what about her lifestyle? Okay, so and then the third thing you need to think about is to assess each drug for its eligibility to discontinued. So how do you decide on that? So drugs which have no valid indication, then you can, it doesn't need to be continued. Again, a lot of medications might be part of a prescribing cascade. So, for example, like with asthma, if someone's already on say a LABA and a inhaled corticosteroid, and then maybe you don't need the lower dose, original steroid inhaler. Okay, and think about whether a harm of a drug might potentially outweigh the benefits. Other things to think about is whether if the condition is completely resolved, then you don't need to continue these drugs. So maybe we want to find out whether the hemorrhoids, maybe they've already been banded, maybe she doesn't need these anosol ointments and all the the laxative drugs. Okay, so again, I think the other thing to think about is, sometimes to make sure, whether the diagnosis is firmly established. So sometimes you see a patient might be put on aspirin because there was some query, chest pain, and query this could be ischemic heart disease. But in fact, it's already confirmed that this patient doesn't have any ischemic heart disease. Then, you can stop the aspirin. And some other drugs, may not actually, confer additional benefits when continued beyond a 7 period of time. So, an example is the bisphosphonate for osteoporosis. Again, after 5 years, you can stop the drug to see, because you might not actually gain additional benefit from that. And also, you might want to think about drugs that are prescribed to counteract the adverse effects of other drugs. So, for example, if someone has got ankle swelling, being on a calcium channel blocker, someone might prescribe a diuretic to counteract that. But in fact, the better solution would be to stop the calcium channel blocker. And then I think Jones just talks about, particular drugs to avoid in older patients, particularly those with strong anticholinergic side effects. So again, these drugs might be preferentially stopped. Okay, So, and also think about drugs that are contraindicated in particular patients. So an example would be renal failure. So, you would, maybe the patient is, has got acute, so maybe, worsening of their chronic renal impairment, then, certain drugs that are, contraindicated, such as maybe, I don't know, metformin or other drugs, like, colchicine, or when they should be really stopped. Okay. So then after you decided which drugs maybe did need to discontinue, then you need to prioritize the order of discontinuing certain drugs. So, the one way to do it is to decide, once, choose based on the greatest, which ones are most likely to cause the greatest harm and the least benefit. Maybe you would choose to discontinue the ones that are easiest to discontinue, which are low likelihood of withdrawal or any disease rebound. Or third, it's actually, as Joe was talking about just now, it's just quite difficult sometimes to persuade someone to stop a drug, even if it's something like a multivitamin. And sometimes you might want to, try to discontinue the one the patient is most willing to stop first, as a kind of a buy-in to prescribe other drugs. So I think this is an outline which kind of summarizes what I talked about just now. Okay. So, back to our case. So, this is just one approach I would probably choose to prioritize the discontinuation. So, I think the first ones I would discontinue is the one with no valid indication or least benefit. So, these kind of creams that's we're not quite sure what they're on, and again, maybe we'd talk to the patient, maybe they don't really need it. So these these pyridoid creams and these things can be maybe deprescribed first. Okay. So, for example, for the GERD, I noticed that she's already on a lansoprazole, which is a PPI. So maybe you could ask whether this disease is already controlled by that PPI, but whether she really needs the Gastril or another antacid. Again, the third one I might choose to prescribe would be the laxatives. So again, why is her problem so severe that she needs a rectal suppository? And again, she's already on 2 laxatives, Senna and lactulose, whether she generally needs both of them, or you can be prescribed one. Okay. And then the fourth one I would probably choose is glimepiride, a sulfonylurea. She's already on insulin treatment. So again, often, because the sulfonylurea can increase the risk of hypoglycemia. So, maybe she doesn't need that medication, and it can be stopped. The first thing I would probably try to address is regarding the asthma therapy. So number one, you would want to check is whether she's using inhalers correctly, assess its inhaler technique. Okay. And then frequently people, although they should be on a regular preventer, they don't often take it. And then sometimes they often just rely on their Ventolin whenever they get symptoms. So you should check whether she is taking those regularly. And I think maybe because she was already prescribed Luciform, which already contains a LABA, maybe we don't need to continue just the Beclaford. And if maybe the Montelukast, again, we would maybe want to question whether she really needs it if she's already using all the inhalers correctly. Okay, then the sixth thing, I think it's a bit more challenging. We noticed that she was on a high number of antidepressant drugs. So, I think these drugs have got high potential for drug interaction, not only side effects, but also, potentiation of, serotonin syndromes. So, but because also, discontinuing any of these medications can, cause maybe rebound of the depression, and also can have a risk of, drug withdrawal. So these drugs, I would probably consult psychiatry for rationalization of these antidepressants rather than, maybe as a non-specialist trying to deprescribe ourselves. Okay, so on the other hand, some drugs that you might definitely want to continue, for example, the amlodipine, a statin for the control hyperlipidemia, and some of the drugs that she does need to stay on. Okay. So, and then the last part would be actually to, implement and monitor the drug discontinuation regimen. So, again, you need to explain and agree with the patient on the management plan, okay? And then try to stop one drug at a time, okay? So that, we can correctly attribute, the effects to specific drugs, and you can rectify if necessary, okay? And then, you should instruct the patient to what to look out for and report if you do experience some side effects, and what actions they can do. Okay, and also importantly, you to communicate your plan to all other healthcare professionals. If other specialties who are also prescribing the drugs, and also document the reasons and outcomes for de-prescribing in your clinical notes. Okay. So I think, so again, this is a systematic review on the effects of de-prescribing older adults. So you could see that actually de-prescribing actually can help, reduce mortality, and also, reduce the risk of falls without any other, effects. So I think so take-home messages about medication review. So there are different approaches to review medications for your patients, and it's effective in improving drug-related outcomes. Okay, and it's important to define, the type of target patients or settings, the type of interventions, and the type of outcomes. And thank you for your attention. And
welcome. I think Professor Chow has illustrated very clearly, and with our case of super polypharmacy. Okay? She has listed out all the steps about how to rationalize the drug use. I think the main hurdle is when you become a doctor, and actually every one of us, any one of us would encounter this problem.